I think, one of the most important messages that I want to share for people who have been diagnosed with prostate cancer survivors, and those that love them, is that you absolutely can live after a diagnosis with prostate cancer, and you can live well. So let's think about some of the ways that the treatments and the disease affect people with prostate cancer, so that if we understand them, we can really try to mitigate them and make that experience a better one. We'll be going through a lot of different complications with a focus at the beginning on the medical complications related to hormonal treatment for prostate cancer. This is something that about half of people with prostate cancer will be treated with over the course of their diagnosis and ongoing follow-up. And then we'll move on to surgery and radiation and some of the complications that can happen from those treatments before we kind of finalize on thinking about lifestyle and summing it all up. So we know, I think, in this room that prostate cancer is the most common non-skin cancer malignancy in American men, and the numbers keep going up. So this year, for 2024, we just saw numbers for new diagnoses, and it's almost 300,000 new diagnoses this year. We had seen with PSA screening changes a few years ago that these numbers went down, and even though we're not screening as many men as are eligible to be screened, those numbers just keep going up. We also are seeing a rise in the number of people dying from prostate cancer. So understanding how to treat it and then to take care of ourselves after a diagnosis is really, really important. So androgen deprivation therapy, or ADT, is also something that we call hormonal therapy. So you may have heard about this if you've had those conversations in clinic, or you've heard of loved ones who might be receiving shots or pills for their hormonal treatment, or ADT. I think it's really important that we recognize that this does not mean we are giving people hormones. This actually means we're taking away the sex hormones like testosterone that drive the growth and spread and activity of prostate cancer cells. Those little cells are actually stimulated by testosterone. It's the food or the fuel that they want to eat so they can grow, divide, spread, and cause trouble. And so one of the main medicines that we use to try to treat prostate cancer and to kill those cells is by starving them, is a medicine or a type of medicines that lower testosterone production by the body and lower signaling through that testosterone receptor or little mouth on the cancer cell that's trying to eat the testosterone. Really importantly, though, these medicines don't act directly on the cancer cells. The medicines that we use, these hormonal therapies, act centrally. They act in the brain to actually cause the signals from the brain to stop signaling the testes to make testosterone. And that causes the testes to stop making testosterone. Those levels drop a lot, and those cells don't have that food. They starve. Many will die. Others will go into deep hibernation. When we drive down testosterone levels in men, this actually also drives down their estrogen levels. These are commonly considered female hormones, but we all have, all of us, testosterones and estrogens in our body. So when we decrease testosterones in men, because of the way estrogens in men are made, that also decreases estrogens in men. So men have both low testosterone and low estrogens, and the estrogen levels are lower than the levels that we see in women after menopause. So really, really just low levels of these sex hormones that maintain many, many parts of our daily function. So to think about this in context of specific organ systems, let's think about cardiovascular disease. This is the most common cause of death in people in the United States, just overall, particularly among men, with cancer, all cancers following relatively closely behind. And the hormonal treatments that we are talking about that lower testosterone and estrogens actually kind of shift the body in a negative direction when it comes to cardiovascular disease and our metabolic system. It causes our cholesterol levels to go up, all the different types of cholesterol. It causes, as we can see in these CT scans, which are cross-sectional images of somebody's abdomen, it causes us to lose those sort of light gray muscles that surround the body, the six-pack, as my kids try to make on themselves. They're 10 and 13. They're really trying hard. In any event, it causes the six-pack to disappear, and it causes a ring of fat to grow around our bellies. And you could sort of see that in those CT scans, and it causes people to gain weight. And I have some slides to show that we can measure that and to show that in people. It also causes our bodies to not process sugars as well. So all of those things are negative when it comes to heart health. So is heart health important in people with prostate cancer? Is it commonly an issue? I said, in general, in men, as we age in the United States, it's a big issue generally for most men. In prostate cancer patients, it's actually really commonly a problem. So there was an interesting study that looked at 100 men who were walking into their urology clinic, 100 men in a row, so that it was just a sample of all those people who came in over those few days. And they found that in those guys, almost 60% already had high blood pressure, about half of them had high cholesterol or dyslipidemia, and almost 20% already had a diagnosis of diabetes. And when they looked among people in that group, how many actually had a diagnosis of heart disease already in these patients who also had prostate cancer, 17% or almost 20% of them also had a diagnosis of heart disease. So when we think about risk factors for heart disease and heart disease itself, 96% of them had those risk factors. So this is a big issue in our community, something we need to be aware of, especially if the treatments are going to make us go in the wrong direction in terms of all of those metabolic things. So only 4 patients did not have a lifestyle or a risk factor or heart disease already. And some of the other seminal work in this area found that those people who have those risk factors are actually at higher risk of developing complications from their hormonal treatment when it comes to heart disease. So if most guys already have the risk factors, and then we look at those people at risk of having more complications, it's those guys with the risk factors, which is basically everybody. So let's look at some of the little bit of the data that we do have in terms of measuring what happens when we start these hormonal treatments. On the top, we can see that over time, from left to right on that top figure, we can see it's 0 through 12 months, so 1 year of time. Those lines that are kind of going up up to the right side of that figure show that we started at the 0 level, no change in weight. That was at 0 time point. And after 12 months, the weight increased by about 4% in general in the guys that were followed on this particular study. And on the bottom, we can see that lean body weight actually goes down over those 12 months, and fat mass went up by 11%. So we have to be aware of this as we're doing our treatments. Now, these treatments help us to control the prostate cancer, and in many settings can help to cure the prostate cancer, but we have to understand what it's doing to our bodies too. And these little squiggles are showing between 0 and 12 months. Generally, they're going up. Those are the cholesterol levels, all the different forms of cholesterol. Luckily, the good form of cholesterol is also going up a little bit, but it doesn't go up enough to offset the bad forms of cholesterol. So this is a busy slide. What it's trying to say is we as a field are working to understand beyond just cholesterol, beyond just body mass, how these effects of hormonal treatment are actually contributing to cardiovascular risk when we think about plaques in our arteries and how all these different hormonal changes can affect. So we are trying to work really hard to understand the immune-related effects and the other hormone-related effects and how that affects the cells and the cholesterol in the body. And work definitely still needs to be done there. But as we're working all of that out, as a field, we do have some guidance to help anyone who's being treated with hormonal therapy try to do something about the changes that I just talked about. So we have a systematic way to care for somebody and to counsel them on what we call reversible cardiovascular risk factors. Those are things that are risk factors for cardiovascular disease that we actually can affect in our daily lives. So in order to be simple, for doctors, nurses, everybody else, we all like to keep it simple, we have an A, B, C, D, E approach. A is starting with awareness. Awareness that these things happen when we lower testosterone and estrogens in patients with prostate cancer. A also stands for aspirin when appropriate, and primary care doctors and cardiologists are the ones who can make those decisions and recommendations if aspirin, baby aspirin or regular aspirin is right for that person. B is blood pressure. We all have the ability to regulate our blood pressure, whether it's through diet and lifestyle changes or whether it's through medications. We can keep our blood pressure in a range that will decrease our risk of having strokes and heart attacks, and that's really important when you're on hormonal therapy. C is addressing cholesterol. That's also something that we can affect through diet, exercise, and sometimes cholesterol-lowering medicines that can decrease the cholesterol and also decrease the risk of things like heart attacks. D is diet and weight management, as well as diabetes, because we can see, and I'll show you in a few slides, that blood sugar is harder to control when your testosterone levels are low. And so some people are diagnosed with diabetes while they're being treated for prostate cancer. Getting that diagnosis and then dealing with that in terms of either diet, exercise, or medicines is really, really important. And then E is exercise, which is really important for all of us so that we can keep our minds and our bodies healthy. So to get on to the insulin and diabetes kind of conversation, we do know in studies that follow patients who are being treated with hormonal therapy that they have about a 36% chance of increased risk of developing diabetes as compared to somebody who does not get treatment with hormonal therapy. That doesn't mean that their overall risk of getting diabetes is 36%. It just means it's 36% higher risk. So we all have some level of risk. This is just notching that up just a little bit higher. Again, not everybody on hormonal therapy gets diabetes. It's actually a relatively low number of people, but it's a little bit higher when you're on that hormonal therapy. So this is some of the data that is the basic science that led us to this understanding. We don't just see more diagnoses of diabetes. We actually, as a body, physiologically have a harder time keeping our blood sugar in a stable and normal level. This is looking over minutes. So the scale on the bottom here is looking at 0 to 120 minutes in both of these figures. And what is happening in these figures is that scientists are measuring sugar levels in a person's blood at several different time points over that 130 minutes or 120 minutes after they got a sugar load. So on the left, this is sugar levels, and you can see there are two lines here representing two different groups of people, one group of people who's not on hormonal therapy, and one group of people who is on hormonal therapy, and those sugar levels are basically the same. On the right-hand side, over that 120 minutes, what they're measuring is insulin levels. Insulin is a hormone in the body that shoves sugar into our muscles, keeps our blood sugars from going up, and if we have diabetes, it takes more insulin to keep the same level of blood sugar because your insulin and your body's not doing that as effectively anymore. So on the right, it's showing the lower line of people who are not on hormonal therapy, lower levels of insulin to keep the same level of glucose. And the top line is a bunch of people who are on hormonal therapy. It takes higher levels of insulin to keep the same level of glucose. So this is insulin insensitivity or prediabetes that seems to be developing in these people who are on hormonal therapy at 12 weeks. So again, this is not a reason to not take treatment for prostate cancer, but it is something to be aware of because exercising also shoves blood sugar into muscles. So there are other things we can do to keep our sugars at a good level, even if our bodies are experiencing these challenges. So the guidelines really incorporate diabetes in there. This is the same cardiovascular guideline that I mentioned before. And for both of these, it's really important that as we are dealing with our prostate cancer and hormonal treatment, we work with our urologist or our medical oncologist, but also really work with primary care doctors or cardiologists, because these are the doctors, or endocrinologists, these are the doctors who specialize in all of these other parts of our body. It's not just a prostate that we're trying to treat. We have to keep ourselves healthy as well. So let's shift gears a little bit and talk about bones. Bones are, we think, just an organ in our body that doesn't seem to change very much, but constantly your bones are being resorbed or are undergoing resorption or breakdown. And on the right, you can see they're also undergoing formation. So they're constantly being broken down and building up all of the time. And our hormones, things like testosterone and mostly estrogens actually, help keep this in a nice balance that's healthy. As we age, there's naturally a little bit more resorption over time than formation, and that's what leads to bones thinning a little bit over time as we get older. When we upset hormones, especially estrogens, we actually shift this direction much further in the resorption direction. So bone breakdown is happening a lot faster than the formation part. And that leads the bones to thin more quickly, very similar to when women go through menopause and their bones get thinner and they might develop osteopenia or kind of early osteoporosis or actually osteoporosis, which is thin bones that might fracture spontaneously. So this balance is upset during hormonal therapy. And this can lead to fracture, most importantly, because thin bones don't hurt, but a fracture like this absolutely hurts. This is an issue for people with prostate cancer that they need to be aware of. We need to keep our bones strong, and we have to recognize bones will thin, so we've got to do something about it. If we have a hip fracture, men have a 25% higher risk of dying after a hip fracture than women. So we want to prevent that. That's never acceptable, right? And they also will lose mobility. They might lose independence, and it certainly costs money to deal with these things. So we want to prevent this for men. And this is some of the basic data that we can see, why do we see that these fractures are happening more? Here we can see on the left-hand side several figures that are showing lines going from left to right. They're going down. That is the bone density over a year for patients treated with hormonal therapy. The top lines that are staying more stable over that period of time are patients who are getting bone strengthening medicines that help their bones to maintain normal, or at least the stable level of bone density. These medicines that we give to women as they go through menopause to keep their bones strong, things like bisphosphonates or something called denosumab, but there are medicines that can stabilize the bone density if you need them, so just to recognize that. And on the right, it's just showing over 12 months really how much of a fall of bone density we're seeing in a separate study. So bone loss is going to happen within 6 to 9 months if you're on the longer forms of hormonal therapy, and we lose about 2 to 3% of bone density per year. So especially over time, something to be aware of, and getting bone density tests to check on that is important. And that's in our guidelines, getting bone density tests to make sure we understand where you start and where you end up over time in terms of the bone thickness and strength, and taking calcium and vitamin D, just like what women do when they're going through menopause or when they're pregnant, when their bones are thinning. These are things that we need to do to keep our bones safe. So let's talk for just a minute about how hormonal shifts affect the way that we think and feel. So I think anyone who's seen a teenage daughter knows that there can be a lot of angst and emotional changes up and down when people are going through changes in their hormones. And boys do this too, but I think it's a little less dramatic in some ways than when girls go through puberty. In any event, this hormonal therapy is like the opposite of puberty. We're taking all these hormones away. And this can cause effects in terms of our mood and the way that we think and feel. So depression is absolutely something that's common in the United States. What we can see here is that on the right-hand figure, about 40% of patients who have a diagnosis of cancer or are at some point going to experience some form of depression, at least on this survey. So something for us to be aware of. This is not surprising, I think, to anyone in this room. And so we have to recognize how our treatments might make that worse. This is a study that's looking over time, from left to right on this figure, over about 2.5 years. And it's looking to see the rates of people getting diagnosed with depression when they're getting hormonal treatment in the yellow line or no hormonal treatment in the blue line. And the yellow line is steeper, showing that there's about a 23% higher chance of having depression with hormonal treatment than without hormonal treatment. And this has been really reiterated in multiple studies. So really important for us to recognize that we're at higher risk when we mess with our hormone levels. We also know that testosterone plays a role in the brain. It actually acts on testosterone receptors in our central nervous system, in our brain. It particularly acts in our executive function, so how we kind of organize everything and get things done. And it also acts in the way that we make memories. And so this is one of the things that we think may be affected when there's a question of whether hormonal treatments, the lower testosterone, may be associated with early dementia or accelerating dementia. And there has been some evidence to suggest, particularly in vulnerable people, that there might be, at about a year in this study, some difference in the rates that people experience declining cognitive function when they're exposed to hormonal therapy versus not. And this is an area of active investigation. Again, we do not think that these treatments cause dementia, but especially in people who might already be developing it, we don't know whether this might accelerate it. So our guidance from the same organization tells us to screen for things like depression, screen for anxiety, talk to patients and talk to their loved ones about whether they're experiencing changes in the way that they're thinking and cognitive decline, so that we can diagnose these things and intervene. We have treatments for depression, anxiety, and we do have some treatments and counseling that we can try to use for cognitive decline as well. So let's shift gears and talk a bit about surgery and radiation. Incontinence is absolutely something that can happen after someone has their prostate taken out. And the reason for this is this little thing called a sphincter. Over on the right-hand side, I drew a little arrow to that little orange thing. A sphincter is something that closes off a tube, and in this case, it's the tube from the bladder, that big bag-looking thing that goes out through the penis. That's the urethra. The sphincter closes off the urethra so urine doesn't just constantly leak out of the bladder. The prostate is in the middle diagram, that red thing. They're right next to each other. When you take out the prostate, you're going to, in most cases, have some effect on that sphincter. It's not going to close as effectively, and so people end up leaking urine. For many men, this is a very common thing that they will need to use Depends or Shields or something in their undergarments to try to keep them dry, and over months this can improve, and if this has happened to you and you've had surgery, you're not alone. Most men will have some level of incontinence. But we use things like Kegel exercises, strengthening the pelvic floor to close off that urethra. And you can, for many men, regain continence by strengthening the pelvic floor muscles to close off the urethra because the other sphincter's been damaged. This is the same set of exercises that we train pregnant women after they've had babies to retrain their pelvic floor, because they only have the pelvic floor as a sphincter. They don't have the interior sphincter. And luckily, if women can train our pelvic floors to keep ourselves dry, I am confident that men can do this too. If they need more, though, there are surgical interventions. There are penile clamps, as you can see. There are things called artificial urethral sphincters, AUSs, that they can put inside the urethra as a surgical procedure to close it off. And a little button inside the scrotum can allow that to open when you want. So there are ways to get dry, and it's important to know about those as well. Erectile dysfunction also happens. We know from surgery that this might happen because the nerves that allow the penis to become erect get damaged when we take out the prostate. They are all around the prostate. This also happens with radiation, though. Radiation causes those nerves to be damaged, and over time they kind of scar over. And so you absolutely can have erectile dysfunction with radiation, too. So know that. Especially over time, as time passes, that fibrosis or scarring gets worse, and the erectile dysfunction from radiation gets worse over time. So recognize that this is not something that's only happening with surgery. Erectile dysfunction and sexual dysfunction in prostate cancer are pretty common, and we have to acknowledge that. We have to understand which part of what's in your particular case, what's happening. Is it related to not being able to have an erection? Is it loss of libido when we lower testosterone levels with hormonal treatment? Is it psychological distress and depression related to the diagnosis or to the treatment? And so we have to understand what the cause is in order to really affect it. We can use different medications, different devices, even an implant in the penis to allow someone to have an erection. But we also have to think about things like counseling and other forms of intimacy if it's more of a psychological issue or a relationship issue. So as we think about all these ways to make things better, I just want to emphasize that the changes that are caused by low testosterone, by these surgeries, these can be affected by many things that you can do: exercise, diet, taking care of your mental health, making sure that we talk to sexual health therapists or others to get the supports that we need is really, really important, because you can do all of these things and you can feel better. There is not a reason to say, I have this diagnosis, I just have to live with it. You can always feel better. And diet and exercise are probably the number one thing here. It helps the mind, it helps the body. And so this is just an excerpt from the Prostate Cancer Foundation's guide to diet and exercise that kind of rates and ranks different interventions, diet strategies, and supplements that you might hear about on the internet, and helps you kind of sort through all the noise to know what's trustworthy and what's not. So ultimately, prostate cancer patients living with or after hormonal treatment are at risk for multiple medical complications that we talked about: heart, bones, muscles, blood sugar, and other systems can be affected. And if we've had surgery or radiation, we're at risk for sexual dysfunction, urinary incontinence, fatigue, and others. So there are things that we can do to prevent these and reverse them. Exercise and the heart-healthy diet, working with primary care can really maximize health. And talking to loved ones about what you and they need is critical, absolutely. And I think I might have a minute or two for questions.
Hello there. Thank you. I've had diabetes for 69 years, and I'm on Orgovix, so I know all about the impact of ADT messing up my blood sugar more than I like. The curious part is I've searched the internet all over and primarily the focus is on type 2 diabetes and not so much on type 1. And I guess my question to you is there any hope there may be more studies, clinical studies, et cetera, on not causing diabetes, but how it affects it, particularly for type 1s?
The question is really, making sure I'm understanding it properly. If one has diabetes, are there studies to help understand how it affects the diabetes? So there are absolutely studies that suggest that blood sugar control after hormonal therapy is more difficult, regardless of your diabetes type. And type 1 diabetes, I think there are fewer studies because there are just fewer people. And so it's really a smaller community, which doesn't mean that they wouldn't be of interest for us to study, but that's probably why what you've read is really focused on type 2. It's a really common thing in many of us as we age. But blood sugar control, regardless of the type, is actually really affected negatively by hormonal therapy.
Thank you, Dr. Morgans. I think we have time just for one final question.
Hi. I'd like to know if you've researched optimum eating time. So I see a diet, and as a survivor, I'm interested in addressing my health issues. And I've changed my routine. I get up early between 6 and 7, and I eat between 6 and 7. That's made a huge difference. Are there studies on ultimate times? I used to pig out at like 8 or 9 at night, and it wasn't good.
Yeah, I'm trying to work at on that pig, stopping that pig out too. So there are definitely studies that are looking at fasting strategies, that are looking at exercise routines and timing. I have not seen the results of these studies yet. Some of the work that's been done actually by one of the members of our medical advisory board, Stacy Loeb, is looking at plant-based diets and finds that the higher degree of plant-based sources of fuel that people get seems like the better quality of life, including things like sexual function. So there are ongoing studies that are really looking into this now, but I don't know, other than the plant-based diet, whether that's been released yet as strong data yet.
Thank you. I actually got permission to go 2 minutes over, so we're going to sneak one last question in.
Hi there. I'm currently on Zytiga and Lupron, and because of that, also prednisone. And I find that the prednisone, I think, is massively increasing my appetite as well, and then plus the effects that you've already described of the ADT leading to weight gain, which is definitely happening for me. I exercise 5 days a week. I eat a healthy diet. I'm trying to figure out how to address really primarily the increased hunger without necessarily going on some kind of a crash diet that would, prevent me from exercising as well, right? Do you have any thoughts on that?
Yeah, so prednisone can cause increased hunger from multiple ways. One of the strategies, or one of the reasons we think it increases hunger is because it actually can irritate the stomach lining. So we always, which gives you this gnawing feeling and feels like you're hungry. So we always encourage people to try to take it with food. So if you're not doing that, I would suggest that. And the other thing you might do is like an acid blocker or a medicine to lower acid, because that can help resolve some of that irritation maybe in the stomach. I wish there was a better fix for this. I would say that I am very interested in working with companies that make things like Ozempic. So these are medicines that decrease hunger, and they're the kind of the fad medicine, not fad. I actually think they're fantastically useful for what they do. They're really helpful in patients with diabetes and causing weight loss because they really stop a lot of hunger. And I only say fad because they're extremely popular, and there have been shortages of these medicines because so many people could use a medicine to sort of decrease their hunger and help them lose some weight and get better blood sugar control. So my hope is that we'll be able to investigate those types of medicines in people with prostate cancer to see if we can proactively use those. They have not been specifically assessed in this group of people, but ongoing conversations, because I do think some of the companies are interested in this well, are moving forward, and hopefully in a few years I'll be able to tell you there's some data there. Sure. Thank you, everyone.